Thank you very much indeed for inviting me here today. So my name is Michelle Williams. I'm a clinical research fellow at the University of Edinburgh. And I'm going to talk today about CT low-dose myocardial perfusion scanning. I'm going to talk a bit about how we do it, and then I'm going to show you some pictures of it in action, and lastly talk a wee bit about where research is and the future questions that we need to ask and answer about this technique. So cardiac CT has been around for quite a while now. Back in the 90s, it was possible to see roughly where the heart was in the chest. You could see there were some coronary arteries, but you really couldn't make any diagnosis on what was going on inside the coronary arteries. However, as the technology and the scanners that we have advanced, and our techniques and reconstruction techniques have advanced, it's become more and more possible to be able to see the coronary arteries and see within the coronary arteries. So this is an example of some normal coronary arteries on our scanner from Edinburgh. So I'm working at the Clinical Research Imaging Centre in Edinburgh, and we have CT scanner, MRI scanner and PET scanner set up in a research environment. We also do all of the clinical scans for cardiac scans, CT and some of the MRI scans for the area. And this is the scanner that we're using for our cardiac scans. We use the Aquilium 1, and this here is our scanner in situ. And these are the sort of images that we are getting from our scanner. On the left-hand side, we've got the coronary angiogram from the CT, and on the right-hand side, we've got the invasive coronary angiogram. And if you look at the lower arrow, we've got a non-calcified plaque, and you can see on the invasive coronary angiogram that the CT and invasive coronary angiogram image correlate nicely. We're seeing the same sort of things. But if you look at the top arrow, we've got a calcified plaque, and what we're seeing on the CT scan really doesn't correlate to what we're seeing on the invasive coronary angiogram, and that's because of the problem we have with calcium. Calcium on a CT scan always looks bigger than it actually is, and that affects the diagnostic accuracy, and in particular, the positive predictive value of studies looking at CT scanning. The presence of calcium affects the diagnostic accuracy. And this is one of the sort of areas that CT myocardial perfusion is particularly useful. In patients with heavily calcified vessels where you can't quite see what's going on, in patients with stents with very high attenuation densities. And we also know from studies like the FAME study that using studies of functional information improves revascularization outcomes. So if we think about a typical referral to a cardiologist, a 65-year-old man, BMI of 27, 1-year history of chest pain and breathlessness on exertion. He's an ex-smoker and he's got a high cholesterol. So he comes to see a cardiologist. They take a history and examination, do a 12-lead ECG. They undergo an exercise tolerance treadmill test. That, as it often is equivocal, so they're referred for a radionuclide myocardial perfusion scan. At the clinic, there's a possibility that someone might have heard a murmur, so he undergoes an echo. The echo windows are poor, so they refer him for a magnetic resonance cardiac MRI scan. Meanwhile, the radionucleotide perfusion scan has come back inconclusive, so he's referred for an invasive coronary angiogram. And any patient going through this list of investigations is probably going to be more confused and worried than anything else. So the perfect diagnostic test for cardiovascular disease would combine all of these things. Information on anatomy, looking at the coronary arteries, the cardiac structure and the vessels. Information on function, the left ventricle, other chambers, at rest and during stress. Information on perfusion of the myocardium, differences between normal and abnormal tissue and differences at rest and at stress. And viability, the ability to assess ischemic or infarcted areas. The perfect diagnostic test would also be non-invasive, safe, have no side effects, be really quick to interpret, really quick to do, and be able to do intervention at the same time. Now, obviously, we can't do all of these things yet. In the future, maybe. But what we can do is this. And this is a protocol that we are using in Edinburgh, looking at CT scanning, cardiac and coronary CT, in a one-stop protocol. And as you can see from this protocol, we get information on structure, function, perfusion, and viability all in one test. And we're able to get the patient in and out in 30 minutes and at a radiation dose for the whole lot of less than 10 millisieverts, using a conversion factor of 0.014 and the average patient size. So the scan is set up almost exactly the same as our normal coronary angiograms, except the patient, instead of having one venflon, has two venflons. When they come in, the nurses explain what's going to happen. They measure their pulse, blood pressure, height and weight, get them changed into a gown, nice, relaxed, comfortable environment. They have a venflon put in the right side and in the left side, the larger one in the right arm for the contrast injection. We then give them medication to reduce their heart rate. And in our centre, we use intravenous metoprolol to reduce the heart rate. And we're aiming for a target heart rate of 55 beats per minute for all of our cardiac scans. And this is particularly important for the perfusion scans. So the next thing we do is the scout images. And we do all of our scout images PA to reduce breast radiation dose. We also tailor the tube voltage and current of the scout images to the individual patient's size and shape to reduce radiation dose as well. Next, we select the volume size. Now, as Russell's already explained, the Aquilian one does up to 160 millimeter detector size. But in fact, most hearts fit in the 120 or 128 detector size. So we want to go for the smallest possible size for our scans because it does impact the radiation dose a lot. We use as our landmark 2 centimeters below the carina for our starting point and then down to the apex of the heart. Next, we select the tube voltage and current for the individual patient, and we do this based on body mass index. We use the same tube current and voltage for the rest and stress scans. And this is one area that's constantly changing. These doses are, these tube current and voltage are much higher than we use for our standard coronary angiograms that we're using at the moment. And at the moment for our coronary angiograms, we're using an iterative dose reduction algorithm for the reconstructions as well. We're not using that for the perfusion studies to date. For the contrast protocol, we use Iomurine 400 protocol, Iomurine 400 contrast agent, and select the volume and rate of injection based on their body mass index as well. So the next thing we have to select is what temporal window we're going to use to do the scan. And for our rest scans, we generally use the prospectively gated one-shot with an acquisition window of 70 to 80%. If the heart rate's above 65 beats a minute, we use a 30 to 80% window for the reasons that Russell's already explained. Now, we have two other options here if we want to get functional information from the rest scan as well, a dose-modulated scan or a constant across a whole R-to-R interval. But generally for the rest scan, we use the prospectively gated CTCA. We use a bolus tracking technique, and we trigger the scan when the contrast reaches 300 units in the aorta for these scans. So that's our rest scan done. Nice and quick and easy, exactly the same as Russell has explained already. The next parts are a bit different. We start an adenosine infusion. We use adenosine. Other sites doing perfusion imaging use dipyridamole, and there are a variety of new A2A receptor agents available on the market being used in other stress imaging techniques, which may be possible to use with this technique in the future as well. We use an infusion of 140 micrograms per kilogram per minute and start the scan 4 minutes into this infusion. It's normally switched off by the time you reach about the 6-minute mark. During the infusion, we monitor their blood pressure, their heart rate, their ECG, and we do provide reassurance to the patient. Adenosine, and as I'm sure many of you know, does make you feel particularly horrible. They're going to get breathless, chest pain, headache, nausea, and that sense of impending doom. But if they know that it's about to happen, if they know that that's really what we want it to happen, because that's how we know the adenosine's working, and if they know that the moment we switch the medication off, they're going to go back to normal very quickly, most patients are very happy to go through it, and we haven't had anyone say stop, stop to us. So for the stress images, we can reduce the detector width even further. So normally it's around about 80 or 100 millimeters that we use. When you're measuring the left ventricle in the axial scan, most left ventricles are about 80 millimeters high. But just to get it all in and not to miss bits, if it breathes slightly differently, we normally go for about 100 millimeters. And then for the stress CTCA, we're using the dose-modulated scan. So we've got at 70 to 80% window, the full tube current, but for the rest of the scan, it drops down to 100 MA. And this works up to a heart rate of 70 beats per minute, and is a lower radiation dose than doing the bottom option, which is a full exposure from R to R interval. With our patients, if we have their heart rate beta block down to 55 beats a minute when you're starting the scan, we give them the adenosine infusion that increases the heart rate by about 5 beats a minute. That means most patients are between 65 and 70 beats a minute when they come to have their stress perfusion scan done. And so most patients were able to use this dose modulation technique. Then we wait for 10 minutes, go in and chat to the patient, make sure they're okay. And then we do the delayed enhancement scan. So this is a very low dose, non-contrast scan with prospective ECG gating, the smallest possible acquisition window, using the same detector range as the stress scan, and using 100 kV to harness the K edge of iodine for greater contrast opacification. And then we check the patient's blood pressure and let them away home. So what about radiation dose? So this is all of the different components of that protocol that you've just seen put together here. And this is the dose length product down here. So the first is the setup for the stress and rest, including the bolus tracking, the positioning slices. And that's averaged from actual patient data because the machine doesn't provide any estimates for that. And the other numbers here are from the estimates from the machine. So you can see that the total protocol radiation dose for an average 70 kilogram person is 614.6 in the dose length product, and that converts to millisieverts of 8.6. So this is perfectly possible. Obviously, in real life, patients' heart rates vary at slightly different sizes. So most people were finding that it's a radiation dose of around about 10 or 12 millisieverts. So a few examples. First of all, this is an example of some left main stem disease. So we've got the CT scan image just here, and there's some calcified plaque in this vessel down here, but what I'm interested in is this plaque here in the left main stem. You can see here in the invasive coronary angiogram, the arrow shows you this same lesion here. So these are the perfusion images that we have. So we've got the rest image, and we've got the stress image here. So the rest image, we've got nice, homogeneous, grey looking all the way around, no problems there. But in the stress image, we've got this dark section just here, this perfusion defect. So I've got a few more pictures of that. Up at the top here, we've got the rest images, and these are slices taken down through the ventricle, and the same homogeneous, grey, nice and smooth, all the way down, no problems. And then we've got the stress image here. And hopefully you can see this dark area up at the top here, and the same here, and the same here, and a little bit of a perfusion defect coming in here as well. And this one here is the perfusion defect from that left main stem disease. So I always find it much easier to look at these as a moving target. So the first one that we're seeing on the left here is the rest images, and you can see nice and smooth, nice and grey all the way down, no problems with perfusion there. And then this one here is the stress images, and it's this area up here that we're concerned about, this dark area compared to the other light areas in the same scan and also in the rest scan. So that's just moving down the ventricle at one phase in the cardiac cycle. And then we've also got functional images. So we can see at that same place where there was that perfusion defect, there's a little bit of wall thickening, and it's not thickening up quite as well as the other areas. Next example is an example of single vessel disease. So we've got the circumflex artery here, and this section here. And these are the perfusion images. So this is the rest scan, and this is the stress scan here. And you can see this perfusion defect in here, and there's this little bit of a defect in here as well. Now, the CT scan can not just show the full thickness defects that you can see with occlusions like that, we can also see subendocardial perfusion defects. So this is an example of a patient's LAD, circumflex, and right coronary artery with a variety of calcified and non-calcified plaques. And this is their stress scan, and you can see this area in the subendocardium here that's darker than the outer aspect. And this last example I've got here is an example of a patient with a stent. And this stent on the standard cardiac windowing was very, very bright. You couldn't see anything in it at all. So I've windowed it right down so you can see at least something inside it. But there's a bit at the bottom here that we're not sure about, a bit at the top here, a bit in the middle here that we're not sure about either. And in the right coronary artery and left coronary artery, there were a couple of little areas that we weren't sure about either. And this was their perfusion scan. So their rest scan here, and their stress scan here. Now, this here, this horizontal streaking, is some beam hardening artifact. And you've got to be very careful not to count that as a perfusion defect. And you can tell that it's a bit streaky, it's not present in every single phase. We reconstruct as many phases as possible out of the information we've got, and if a perfusion defect has to be there in at least 3 of them for us to call it a perfusion defect. So this is an artifact. However, this is not. This is a perfusion defect just here. And the patient went on to have an invasive coronary angiogram and stent. So this is a different patient. This is a patient we scanned on Wednesday. And we've got an MRI scan here and a CT scan here. And in the MRI scan, you can see this area of delayed enhancement just here. And this is the corresponding CT scan. So you can see very similar in size, very similar in shape. Obviously, at the moment, it's very easy to quantify delayed enhancement on MRI, and hopefully in future it'll be just as easy on CT. There's definitely some work to be done in the quantification, but the visual identification is definitely there. So if you've done any reading about perfusion, you'll probably have seen this graph. This is taken from the George paper from the Hopkins group. And what it's showing is, first of all, we've got the left ventricle, contrast enhancement over time as the bolus comes in. And then we've got this white triangles being the normal segment, and the dark blobs being an abnormal segment, a Snow's segment. And what we're looking for is this difference in Hounsfield units between these 2 lines. So obviously, if you're too early, you're not going to see anything at all. If you're too late, you're not going to see a difference at all. So it's somewhere in here that we want to do our scans. So research to date, this is all the research in perfusion up to 2010. Obviously in 2011 there's been a few more papers out. But you can see from here we've got quite a variety of different stress agents being used, a variety of different scanners. They're comparing it to a lot of different things. We've got MRI, invasive coronary angiogram, nuclear medicine, and they're doing quite a lot of different analysis per territory, per segment, per patient. The numbers of patients in all of these are quite small. 40 is the maximum. A number of segments assessed in that is 687, which must have taken quite a while. But in general, they're all showing the same thing. Sensitivity, specificity, positive and negative predictive values, somewhere between 80 and 90, up to 100% for some of the numbers. So there's quite a few questions still to be answered. The first question I have is, do we do the stress or the rest images first? If delayed enhancement is really that easy to see, we've got to be very careful to avoid that affecting our images. The second question is the problem of Schrodinger's cat. We're giving people lots of different medications, beta blockers, contrast, adenosine, nitrates. The hope is that these don't affect the perfusion defects that we're seeing. But it's very difficult to know at the moment. Then the issue of timing. Our protocol uses a one-shot snapshot, 70-80% window. We get about 9 or 10 images to compare within that snapshot, but that's only over about a couple of 100 milliseconds, so we really have to be sure we're getting it at the right time and have a way to do that robustly. Next is the accuracy in larger studies and versus other functional analysis. We've got a few studies looking at MRI, FFR, SPECT, and the Core 320 study will be coming out very soon. Next is the clinical application. We can do it very well in 30 minutes in our setup, but it's how to extrapolate that to a busy clinical department. So in conclusion, global assessment of coronary heart disease is possible at modest levels of radiation dose with this CT technique. And this does hold major promise for the future management of patients with suspected coronary heart disease. So I'd like to acknowledge my colleagues in Edinburgh and elsewhere, both in cardiology and radiology, medical physics, radiographers, and image analysis. It's obviously taken a lot of work to be able to do what we're doing today. Thank you very much.